What I'm going to do is start by going over the guidelines for the medical and surgical management of severe head injury. For your information, they were just recently updated to the 4th edition. This is a free resource. You can download this online if you go to the Brain Trauma Foundation. It's essentially the real ultimate resource for the management of head injury. So the usual introductions. Oh goodness. So annually, 2.5 million people with TBI die in the USA alone. 283,000 hospitalized, 52,000 died, which is about a third of all the injury-related deaths. MVAs, falls, and blunt injuries are the largest portion of TBI, but we're not in the United States right now. So what about Sub-Saharan Africa? Here, injuries result in 4.8 million deaths per year annually, responsible for 10% of deaths globally. And the incidence of TBI in Sub-Saharan Africa may be 3 times higher than the global incidence, and is predicted to reach 14 million by 2050. And you're probably seeing that because the more roads that get created, the more motorbikes are on them, and the more people on motorbikes without helmets results in the obvious. So this was actually looked at pretty recently for the center in Tanzania, where they took a look at, number one, the incidence of injury there, and then they looked at the incidence or the adherence to the Brain Foundation guidelines. And the summary is that, unfortunately, the guidelines aren't really held to because of the resources in the region, not by lack of trying or fault of the practitioners, but the lack of emergency services or other modalities and methods. And you can see that the 2-week mortality in this group of patients is 34.8%, 35% underwent a craniotomy, and 38% received hyperosmolar therapy. So what are the treatments that we're going to discuss with these guidelines? Well, some of the updates that are important include decompressive craniectomy, hypothermia, hyperosmolar therapy, CSF drainage, ventilation therapies, anesthetics, steroids with nutrition, infection prophylaxis, DVT prophylaxis, and seizure prophylaxis. In terms of monitoring, what we're referring to is intracranial pressure monitoring, cerebral perfusion pressure monitoring, and advanced cerebral monitoring, which are different categories. What we look for, we call thresholds in all of these categories: blood pressure, intracranial pressure, cerebral perfusion pressure, and other advanced monitoring thresholds. When we look at how these patients are managed, this little grid kind of lays it out: traumatic brain injury, pre-hospital care, emergency department, and then the grid extends into that medical management and potentially surgery. I think the gap here is at the top grid, which is the pre-hospital care. Unfortunately, patients get injured, and it can be several hours to days to longer before they get to hospital. And I think that that is an area that we like to call the low-hanging fruit, where there's room for improvement with some services being rendered to allow patients access to care, which might have a really good impact on their survival and their morbidity. When we talk about levels of recommendation with these guidelines, level 1, level 2A, 2B, level 3, basically that level of recommendation gives us the confidence that that recommendation has data to support it, and what we're doing has a justification, rather than this is the way I do it and I have no way to prove it's right or wrong. So level 1 is the best stuff, high quality body of evidence. Level 2A, moderate. Level 2B and C, or mostly retrospective, case-controlled data sets. So I'll go through some of these things pretty quickly, and as I mentioned, hopefully these talks will be made available to those interested so that you'll have all of this at your disposal for education purposes. So blood pressure. There's level 1 and 2 evidence. There there's insufficient evidence, rather, to make a level 1 or 2 recommendation. So what you see a lot of these recommendations is basically we don't have data that's robust enough to make a definitive decision. Okay, what we do have is level 3 evidence saying that keeping the systolic above 100 for patients 50 to 69 years old, or 110 or above for patients 15 to 49 may be considered to decrease the mortality and improve outcomes. So, you know, there was a recent study actually that was done in the South American control group that kind of shook up the head injury community, as it were, showing that maybe there wasn't much of a difference at all. But currently it is considered a recommended modality for monitoring. And basically it's considered appropriate in severe head injury patients with abnormal CT or a normal CT scan if 2 of the following are noted: low blood pressure, age greater than 40 years, or motor posturing. That's usually in a Glasgow Coma score of 8 or less. Recommendations. You know, in the current state of technology, a ventricular catheter connected to a strain gauge is most accurate, low cost. It allows also therapeutic drainage of CSF. Putting in what we call an ICP bulb or fiber optic is a very simple technique, but does not have the advantage of CSF drainage. It can also probably cost more money per device. And just for some illustration, the placement of a ventriculostomy is based on specific landmarks, trajectories, and the like. And this is a CAT scan with a well-placed tube, probably not one of mine. Treatment thresholds, level 1 and 2A. Again, it's a little disappointing to give this talk sometimes because every slide is, well, there's insufficient evidence to support level 1 or 2A. And this is kind of what was referred to earlier, where we hang on to the studies that are really good, like the Patchell study or these others, because it's level 1 data to support that when you make a decision about surgery, it actually is a good idea, and there's data to support its use. But here we do have data, it's just not that highest of quality. But what we do know is treating an ICP above 22 is recommended, because we know that values above this have increased mortality. A combination of ICP values and brain CT may be used to make management decisions, and this is just kind of the obvious. Drainage. Drainage is also insufficient evidence, but using EVD system 0 and trying to monitor and then drain CSF is considered reasonable. Sorry, guys. There we go. CPP monitoring. So this is a more advanced technique. CPP monitoring done here with the integrated advanced monitors. That's something that's done in any of the local hospitals or in Nairobi, even in the Aga Khan, I have resources. Well, we'll talk about it very quickly because the punchline is the same. It's insufficient evidence to support level 1 recommendation. But using this technique may help us get more data to manage the patient. And again, the thresholds are what we look for. So with the recommended target CPP is between 60 and 70, and it's really unclear what the optimal answer is there. Avoiding aggressive attempts to maintain CPP above 70 with fluids and pressors may be considered because of the risk of adult respiratory failure. So going crazy and taking someone up and putting on pressors to go after a number in a patient who can't handle the fluid load may not be a good idea. Advanced cerebral monitoring, that would include jugular valve and various techniques of fiber optic local perfusion methods. These are all also insufficient evidence. Let's get to things that we do. Hyperventilation. So there's insufficient evidence to support recommendations, and that's fine. But what we do know now is that prolonged prophylactic hyperventilation with a partial pressure carbon dioxide 25 is really not recommended. So if a patient is doing something quite terrible and you back them down real quickly, no one would follow you. But keeping someone on an extraordinarily high rate to keep them down there probably has profound negative effects. Hyperosmolar therapy, mannitol. Again, hyperosmolar therapy may lower transcranial pressure. There's insufficient evidence about the effects on clinical outcomes or the use of any specific hyperosmolar agent. So in the States, there's always plenty of debate whether or not you should use hypertonic saline versus mannitol versus a combination thereof or otherwise. And I think that, first of all, you got to go with what your resources are. And then second of all, I think it's a matter of keeping the patient in a bulimic state that they can tolerate. Hypothermia, I think that right now, short-term prophylactic hypothermia is not recommended to improve outcomes. DVT prophylaxis. So this is an important one in all of neurosurgery, and we've become a lot more aggressive with the treatment of DVT. Level 3 evidence states that it may be used in combination with mechanical prophylaxis. There may be an increase for expansion of intracranial hemorrhage if there's an associated finding on CAT scan with that. Anesthetic agents, using burst suppression techniques is no longer recommended with barbiturates or otherwise. Propofol may be a useful agent to control ICP, but it's not really noted to improve mortality or 6-month outcomes. And then propofol in children has to be considered because there are some rather problematic side effects with that medication in the pediatric population. Steroids. To this day, the emergency room doctor asks me if they want to start steroids on the head injury patients. And the answer is no. Okay? Here's one where you have to really say, I know the answer to this one. The use of steroids is not recommended for improving outcome or reducing ICP. So if you don't get anything else out of this talk, just don't give steroids for head injury. Okay? There's a good study. They call it the CRASH trial. All these studies have nice acronyms. That one's easy to remember. But basically, they showed fairly definitively that the use of steroid medications in the presence of an acute head injury is not a good idea. Seizure prophylaxis. So we had this conversation regarding perioperative care of the patient with a tumor, but some of these things apply certainly with head injury. Level 1, well, we don't have sufficient evidence to sort of lay down the law, but what we do know is that certainly on paper, studies have suggested prophylactic use of phenytoin and valproate is not really recommended for preventing post-traumatic seizures. Phenytoin can be used for reduction of early seizures within about 7 days of the injury, but however, the overall benefit is unclear, and so that's something that's up for debate. I think logic suggests also that early post-traumatic seizures seem like a terrible thing, and they are a terrible thing, but it really isn't associated with worse outcomes overall in most of the larger studies. Infection prophylaxis, certainly what we're worried about generally is ventilator persistent pneumonia and other problems with a severely injured patient. So now what we do for patients that we don't believe are going to wake up anytime soon, we advocate for early tracheostomy, feeding tube, things of that sort to be done up front rather than develop long-term complications associated with infilling catheters into the mouth and nose. In terms of impregnated catheters, again, that's something that in the United States we have these fancy catheters that have antibiotics impregnated into the plastic, which may be useful when using an EVD, but here I'm guessing it's probably not something that's readily available. So let's just shift gears before we all fall asleep and I can get you guys to lunch. We'll talk about some of the surgical stuff and the injury types, okay? So the major types of head injury include subdural hematoma, epidural hematoma, an intraparenchymal hematoma, posterior fossa hematoma, and then the traumatic subarachnoid hemorrhage. Okay? So this slide has a good look at the various injury types. Up top, we have the CAT scan showing what's often referred to as diffuse axonal injury. It doesn't look like a heck of a lot, but the brain is inflamed from injury. On the bottom, what we have are the classic injury types. Subdural hematoma, okay, because the hematoma is between the brain and the dura, likely because of a ripped vein. And you can see that large hematoma going over the convexity of the brain. Here's the classic epidural hematoma outside, likely due to middle meningeal artery outside, so that's a lens-shaped. Okay, here's a intracerebral hematoma, and then a contusion, which usually blossoms into a hematoma. It's important to have some idea about the anatomy of the skull, and we're going to do a little bit of a workshop about that in terms of how to do some procedures. Here's an obvious epidural hematoma here on the right. Okay. So there are surgical guidelines, and the surgical management of the acute epidural hematoma is essentially surgery when the Glasgow score is less than 9, or you have one that's volume is greater than 30 cc's. There are very, very small epidural hematomas that are wisps and otherwise neurologically intact patient where you can't observe them. Anyone with a neurologic decline probably would be best served surgically. This sort of describes what that hematoma pattern is, where you can see the blood clot in between the skull and the dura. And so the technique of removing it, is a craniotomy, whereby the blood is removed off the surface of the dura, and then you find that bleeding artery and coagulate with the bipolar when it's working. Okay, subdural hematoma, obviously seen on the right. Again, indications of surgery. Thickness of greater than 10 millimeters or midline strip greater than 5 millimeters should be surgically evacuated. These indications and timing and methods, of course, are not really based on the best level 1 data, but this is kind of the best we can do. So it's good to have a roadmap on paper. And so the idea is to get this done as soon as possible. And so we talk about the 4-hour time period indicating the best possible prognosis. Sooner rather than later. Yes, sir.
So yeah, what's your opinion on, say, octogenarian, has tons of room, has a 12 mm subdural, no shift, no mass effect?
So in something like that, where it's a head bunk, maybe on aspirin, they have atrophy, they have tons of room, they have no neurologic deficit, and really no shift. Sometimes they can be watched. Sometimes what will happen with them is they'll liquefy and turn into a chronic subdural hematoma, and that might be evacuated via blowhole, which is a less invasive way to go about it. So there are cases that you can consider that. We're talking more about the younger population, GCS in the 90s, which would require more urgent treatment. That's a good point, though, and that's where you have to be a doctor sometimes and not a surgeon, and really assess the situation and find out what's going on. And I think also we could get into the whole ethics of surgery in patients who have poor prognoses, but that's not for today. So here's some pictures of the subdural hematoma. I thought since we're doing the workshop later, we should see what these craniotomy techniques look like. And basically, moving through positioning, you can see there's a roll. We have all of these things here, verbal incisions. Posterior Fossa hematoma, a different animal altogether. Back here in the region of the cerebellum, there are indications for that. Prone position, removing the bone from the back of the skull is a different technique than the standard craniotomy, and then removing the hematoma in that regard. Contusions, well, generally patients with contusions we monitor clinically, but now we talk about decompressive craniectomy as an option for these patients, and I think that that's something I'll touch on very briefly before closing out. Depressed skull fractures, open depressed skull fractures, generally it's agreed upon that they should be elevated, degraded, either repaired or closed. A simple non-depressed closed fractures don't need a surgery. So I'll touch briefly on decompressive craniectomy. Basically, the technique is removing a large portion of the skull to give it more room in the face of a severe head injury. A couple of recent studies have been performed, and unfortunately, the data doesn't suggest that there's a overwhelming benefit to our patients using this technique. The first study was done based on a large bifrontal technique or 2 large craniectomies in the face of diffuse head injury, and the data did not suggest a significantly improved outcome with these patients. This was followed up with what was called the Rescue ICP study, and actually our site participated in this, and we were in that 1 billion author list on the bottom that no one ever reads. But it was an interesting study because then it was looking at decompressive craniectomy, but using a treatment paradigm that was a little bit different, maybe even just a unilateral craniectomy as opposed to that bifrontal technique. Unfortunately, it turned out that we never got the level of evidence we needed to make a recommendation, and basically the things that we did get out of it is that bifrontal decompressive craniectomy is not recommended to improve outcomes as measured by the GCS. And a large frontotemporal parietal craniectomy is recommended over a small one. So if you're going to do this, the story for this is go big or go small, go home rather, because if you do a little craniectomy in the face of severe head injury and intracranial hypertension, the brain will squeeze out, you'll get necrosis and ischemia around the border of your craniectomy, and you'll do more harm than good. These are some slides showing some of the techniques for that and different ways you can open the dura. And so, lastly, you can see here, and this is part of, if we have the skull sawbones, we can look at this or otherwise, hopefully on Monday we'll have one or more cases that we can go over. The video does show a fairly nice display of craniotomy being performed.